All right, welcome everyone to December's NASCI's Curious Cases webinar. I'm Jacob Kirsch, welcoming you all to our webinar. So thanks for being here. We're starting to see a few people trickling in, so why don't we get started? I know Dr. Denny on the call. She has a few cases to share. So Carol, you want to start? I want to make you the presenter. Perfect, thank you. You are probably muted because we don't hear you.
I am unmuted now.
There you go. Now we hear you. Perfect, thank you.
Yeah. All right, so the first case I have is a 29-year-old woman, 2 weeks postpartum with acute chest pain, elevated TNI. And she started out with an MR looking for myocarditis. And so we have 3-chamber and 4-chamber views, and I think you can appreciate some wall motion abnormalities, mainly in the anterior wall and also at the apex and the distal septum. And perfusion, dynamic perfusion here shows significantly reduced perfusion in the anterior wall, kind of mid-wall here. And then delayed enhancement images show pretty much transmural enhancement, distal septum, apex, and in the anterior wall. And here this dark area probably represents an area of, I'm blanking, Jacobo, what's the term I'm looking for?
Patches,
but the dark
microvascular occlusion.
Sorry?
Microvascular occlusion.
Yes. Had a sudden senior moment there. So so definitely this is you know an ischemic pattern. There's decreased perfusion, and then there's an ischemic pattern of enhancement. So very useful in this patient who, you know, the differential was myocarditis, I guess Takotsubo, but she's pretty young. So we have an ischemic event here. So she had an angiogram, and you can see, I think it's going to play again, but there is narrowing or stenosis of the left main and LAD extending into some diagonals here, and it's quite smooth and has a funny kind of shelf-like appearance. So this, and it extends into one of the diagonals. So this is a spontaneous coronary artery dissection in this unfortunate young lady. And just to complete, she had a CT, and much more difficult to perceive on the CT because of the decreased spatial resolution. But if we come back up, I think you can appreciate a linear density in the left main, and then kind of some irregularity along the LAD and first and second diagonals. And this is multiplanar reformat, and probably if I stop it here, you can appreciate this linear density through the left main and proximal LAD consistent with a dissection. So SCAD in a young postpartum woman. Any questions about this case?
Pretty nice images.
Yeah.
So let me ask
All
you a
right.
question. Let me ask you a quick question. See if you or anybody on the call knows this. There is such a thing as postpartum cardiomyopathy, correct? That's reversible. In the past, do you think there was some overlap and we were confusing some the stress of the postpartum, developing some SCAD in some of these patients, and we're confusing them with the postpartum cardiomyopathy versus self-resolving SCAD?
That's a very good question, Jacobo. Has anyone asked that question in the past? I haven't seen anything published on it.
No, me either.
Yeah.
All right.
Is anyone else on the call? But it's quite possible, that that's what it was.
I'm sure there was some overlap in diagnosis.
Yep. Next is a 56-year-old woman with mixed aortic stenosis and regurgitation for pre-op assessment. So we were asked to assess the coronaries and aortic size. So she had a coronary CT. You know, many of these patients have normal coronaries, so they just want to assess the coronaries prior to aortic surgery. So certainly the ascending aorta is dilated and the aortic valve is thickened. And it was tricuspid and the coronary arteries are normal. I'll just scroll through it one more time. See if you pick up anything else that might be of interest. The left atrium is a bit large and the left ventricle, she may have an interatrial septal aneurysm.
Is there
So
a little vessel? Is there a little vessel
Pardon
anterior
me?
to the? Is there a little vessel anterior to the aorta, like an arteriovenous? It's just not enhancing much. Right there, over the pulmonary artery. That's just a vein. It's just a venous variant. Okay.
I think it's just a little vessel, yeah.
It's a venous variant, yeah.
So I'll show you a sagittal oblique, and this will be helpful. Scroll through again. And again. Maybe if I slow it down.
Oh, very nice.
I don't know if any of you picked up, there's a small channel between the distal aortic arch and the main pulmonary artery. So there's a small PDA, and you can actually see, if I can pause it here, you can see a little bit of a change in contrast from the jet going from the aorta, just a little bit less contrast in the aorta than in the pulmonary artery in this case. Probably more obvious in this angiogram of the CTA of the aorta, where you have very little contrast in the pulmonary artery, and you can actually see that jet. And the main pulmonary artery is quite large, and the left atrium is large. So we did mention the PDA in 2015 and recommended further imaging, echo, and nothing was done. So this is 4 years later in 2019, and the pulmonary artery is larger, the left atrium is larger, and the left ventricle is larger. And I guess they eventually did not do surgery on the aorta and the aortic valve because the valve wasn't severe enough to do surgery on yet. And just gated 3D SSFP showing the same finding with the PDA and the jet here in the main pulmonary artery. So this was followed by MR. You can see the mixed aortic stenosis and aortic regurgitation here, and you can see a jet in the main pulmonary artery on the left and middle images coming in as a result of that PDA. So, and then on this coronal, on this LVOT view, you can see also the jet in the main pulmonary artery. And quite a significant shunt here. So this warrants a surgical repair. So this was discovered as an adult. It's pretty uncommon to discover these as adults, but it does happen. And they're really, really easy to miss if you don't review, you know, the coronal and the sagittal planes. They're really hard to pick up on an axial image, and you can just walk right over them. So just always inspect that area carefully. Any questions? All right. Case number 3, 56-year-old man with non-STEMI. He had an ad hoc stent placed in the LAD. But his angiogram also showed a chronic total occlusion of his right coronary artery. And his echo showed what they thought was a basal infraseptal aneurysm or a pseudoaneurysm. They weren't too sure, so he went on to have an MR. And these are the short axis cines. I'll just run through it one more time. You can probably appreciate an aneurysm here that looks very thin walled, some very abnormal septal motion. And I'll just run through it again here. Kind of a weird dephasing jet happening near the apex here. So let's look at that more carefully. The 4-chamber cines here show this aneurysm of the septum. Very abnormal or almost no septal motion or thickening here. And then kind of a little jet that we're seeing from the left ventricle through this aneurysm into the right ventricle. And this is, not sure if you can see my pointer here, but just the inferior aspect of the aneurysm. And I think I'll just stop these so I don't crash my PowerPoint and run this. Again, you can see this little jet coming from the left ventricle through the aneurysm into the right ventricle. So this is a VSD, and the wall of that aneurysm is akinetic and very thinned. And these are the LGE images, and basically not, I think you can't appreciate the wall because it is of the same, enhancement as the blood pool. So this is all infarcted, chronic old, infarcted septum with a post-infarction VSD. And the QPQS here was actually quite high at sorry, I did that. Okay, 3.8. So this patient went on to have surgical correction of this aneurysm and VSD post-infarct. But this was completely unknown, quite chronic in nature, and the patient had come in with a non-STEMI and had an LAD stent. So this was a fortuitous discovery. Any questions on this one? Okay. Last case is a 76-year-old man post-TAVI who had pericardial tamponade. He had a pericardial drain placed and it was left in place, and they asked us to rule out aortic dissection. So the unenhanced CT wasn't particularly helpful. There was a bit of high density blood in the pericardium. And you can see the valve in place and then the drain in the anterior pericardial space. And I must say, initially we walked by this because we were looking for more of an aortic dissection as opposed to what this turned out to be. We haven't seen too many of these. So I'm just going to scroll back and forth here and ask if anyone is seeing some contrast that doesn't belong. So I'm glad it's not jumping out at all of you. So we had a second look after the surgeons came by, and this is kind of an axial oblique, but you can see this outpouching of contrast. It's really right at the annulus. So it's a small focal tear. And then on this sagittal oblique, you can see the tear anteriorly. So this was managed conservatively. He had 2 CTs about a week apart and didn't rebleed. And we presumed that that was the source of the tamponade. And I do think that he was discharged from hospital and is doing okay. but that was about a month ago. So we'll see what happens in the long term. So focal tear right at the annulus. Any questions there?
Nice case. And there's a fair amount of subannular or annular calcification, which predisposes those little tears.
Yeah, exactly. Yeah, yeah. Okay, well, that's all for mine.
All right, thank you so much, Carol. I know I can show a couple of cases as well. Let me share my screen. Let's start with this case because I think that's a nice segue to this one. So I have a case that I kind of put together here as a short PowerPoint, and then we're just going to use the viewer to review a couple other cases. Let's see. All right. So the story, this I'm going to make up the age. We're going to call it a 60-year-old male. He was transferred from an outside institution, a little bit rural area, um, immediately to the hospital. This is an older case. A patient was presented with acute chest pain to the local emergency department, and then they were trying to do a coronary angiography, and patient just started decompensating, chest pain got worse, and ended up being transferred immediately to the hospital. So I would really appreciate comments here on this portable chest X-ray. This, I think, is a very nice X-ray for any trainee on the call.
There is a permanent of the ascending aorta. With the chest pain, we need to rule out some sort of aneurysm or dissection. Or
That's, yeah, very good. But more than prominence, if you, it's hard to describe that at first until you really look into it. We have almost like a silhouette sign. Now you can actually follow the lateral contour here, the right lateral contour of the aorta, over the rest of the cardiac structures, right? Usually it's all the same density, all the same white density. We don't follow the specific borders of the structures in the cardiac silhouette, just kind of like the contours, but not internally, not over the within the mediastinum. So this was very apparent. So it's not just a bit prominent, but it's very, very bright, and you can see it very well all the way almost to where you would expect the aortic valve to be present. So I hope that's projecting well on your screens. So
Is that contrast?
Yep. So this is what came with the patient on a little CD from when they were trying to do the coronary arteries, and you can see they're doing the aortogram. And any comments on that? Is that pigtail where it's supposed to be?
No.
No, it doesn't. It doesn't seem like it. Yeah, there's a lot of pulling of contrast across the aortic wall. So this is a case of iatrogenic aortic dissection. And this is a CT when the patient was burning straight to the scanner. And you can see there that contrast in that false luminance surrounding the aorta. That's all from the original angiogram. There was no contrast given for this CT exam. You can see how much the pressure of the contrast is putting quite a bit of mass effect on the aorta, which is a high pressure structure to start with. And then as we go down, yeah, we do confirm that the patient has significant atherosclerotic disease. You see all the calcifications in the coronaries, but also you can see that dissection extended caudally into the pericardium, so it tamponed the patient. Unfortunately, the patient did not survive the event. It's a pretty old case, but I think it's a nice teaching case. So I was looking at the literature to see incidents and what we knew about these iatrogenic aortic dissections, and this is a paper from just a few years ago, about 5 years ago, Again, we know that the aortic dissection can have high mortality, but and when it's iatrogenic, we know that it's very, very rare. Some of the small case reports and series, they say about less than here, it's there, 0.06%. So this is really about 1 in 2,000 cases. That still sounds a bit high if you think about how many cardiac caths happen at your hospitals every year, and we really rarely see any of this. So that's on the high side, if you ask me. And a few of the interesting take-home points that I got from this paper: there's very little data, very, very low overall frequency, and after the acute phase, that very acute moment, if the patient somehow survives that very acute moment, which is most of the time actually, there's a spontaneous evolution of this is excellent. It kind of resolves almost like a I guess as most cat could. And again, what was also very interesting is in those patients that present with acute coronary syndromes, they were still on the antithrombotic treatment for the acute for the coronary disease, even though there was an aortic dissection, which when you think about it as a isolated, not a non-iatrogenic, but an isolated aortic dissection, you wouldn't treat those patients with antithrombotic or any anticoagulant treatment. So even with those patients do well again once they pass that acute phase. I thought that was kind of interesting and a bit counterintuitive. All right, so that's that case. Any questions or comments about that case?
I wonder if it's underreported because or our center is not very good. Because I mean, I probably see 1 or 2 a year, not to that extent though, but some sort of focal dissection that they want us to do a CT for. Often it's just limited, especially around the right coronary. It's more frequent in my experience. But I do see 1 or 2 a year.
Yeah,
I don't know. Do other people have that experience?
I don't see that many, to be honest with you. Maybe 1 every other year or so.
They must have aggressive cardiologists.
Yeah. Or you know, the protoplasm, the patients. All right, let's see. Let's do the MR last. So this is just a quick show and tell as well, because I have never seen this. I've only seen this one case. This is a patient status post tricuspid valve repair with annuloplasty. So you see the sternotomy wires, and there's some long issues you can tell even in these long bone windows. And you can see here the wire from the annuloplasty on the tricuspid. Here's also in the base of the heart. This is a somewhat systolic phase, so it looks like the ventricle may be a bit thickened. It may be, but again, it's on the systolic part of the cycle. So anything that catches anybody's attention? Let's see. This is a good view. Go ahead.
Right ventricle. There's an outpouching of contrast net to the right ventricle, but it's near the sternotomy wires. So I'm wondering if it's a perforation or a pseudoaneurysm.
Yeah, it's right here.
Coronary?
No, it's separate from
Next
the coronary.
to the right corner.
Apart
Separate from the coronary. Yeah, and right here, and it seems to be communicated with it's communicating with the right ventricle, like you mentioned, right at the level of where the annuloplasty was performed. These images here. So we were speculating that this may be related to the annuloplasty, like a small, you see right there, it's right at the edge. Here's the neck, like a pseudoaneurysm or a post-procedural pseudoaneurysm related to the valve repair that happened. So iatrogenic in nature. Had never seen it though. We've seen pseudoaneurysms around usually the aortic valve, and they're not that infrequent. I mean, they're not common, but we do see them. But I had never seen one around the tricuspid valve, so just a little show and tell of that one. And again, all comments are really good. Was it related to this sternotomy or something else, or did the patient have it from before the surgery? But I would have assumed that they had seen it and tried to repair. So that's this case. Has anybody seen tricuspid valve related pseudoaneurysms?
No. It's cool that you know there's no muscle in it because the contrast has stayed pooled in there from the right ventricular ejection on.
Yeah, it's not being pushed out.
Mm-hmm.
This let's see, this is a younger kid. I believe he's 9 years old. Again, this is not a very new case, but I thought it was a great case to show. It's a black blood sequence, a double IR. So I think there's a couple of things that are interesting. I think first of all here, the left ventricle. Any one of the trainees want to try and tell me what's all this stuff here in the left ventricle?
Be a non-compaction.
Very good. So I think here, this is just a single shot, but you can see some of that non-compacted myocardium. It's quite prominent actually. Here we go. This one is going to. You can see it here on the SSFP as well. You see the striations or the non-compacted myocardium in the left ventricle, so it's pretty prominent. This is just one image. I want to see if I have nice cine images to show you that, which I think we do. This is just, again, you can see that. So you can see there that area of non-compaction is almost half of the left ventricle. But that's not all. The really interesting part in this case, that was kind of like an incidental finding actually, is here. Where are my 4-chamber movies? Let's see. Maybe this one? No. No, some of that. Sorry about that. Let's see this one. Yeah, just has to go through the heart. So look at the the right chambers. So there's a couple of things. Number one, the AV groove for some reason is very, very deep, is very prominent. But also, what is the structure right here? Mid right ventricle. And you see there's a chorda coming from it, attaching to the valve here. You see that there? I'm going to try to scroll slower, so if there's a lag on your computers, you can kind of see it moving with it. So you can see it there very well. So basically, this is the medial part of the tricuspid valve leaflet that has been completely displaced anteriorly or apically towards mid-ventricle. So that's Epstein's anomaly. So that's where there's malposition of that valve. So there's not a lot of tricuspid insufficiency in this case, and we don't see that huge right atrium. My theory is, and I don't know this as a fact, is because of that additional malformation of that very deep AV groove, it kind of retains some of that coaptation of the valve leaflets, and that kind of prevented the patient from having that severe tricuspid insufficiency that goes along with Epstein's anomaly. So it was the patient was imaged for that, and then we found the non-compaction as well. I have not read that there's any specific correlation with Epstein and non-compaction. To be honest with you, I don't know if that's. I don't believe it is, but if there's a correlation. All right, and those are my 3 cases. Any comments about this one? All right, let me.
Just about non-compaction, I have just a small question. I know the criteria, MR it's 2.3, the ratio, but if you don't have cardiomyopathy associated with it, do you call non-compaction of the left ventricle when you have the ratio, or you need to have some other finding for you to call it?
No, you call it based on the finding of that ratio. You won't always necessarily have significant enough wall motion abnormality or something else along with it. It's an anatomical diagnosis, not necessarily a functional one.
Okay, thank you.
No, please.